today's test will be basically, can you hear? Can you hear properly? If you cannot understand, raise your hand and ask questions. No issue. So try to understand today, and then you will do the actual test next Wednesday. Okay. I wanted to show the video, but unfortunately I thought that there will be online facility will be there. It is not there. I cannot connect it with my mobile also. I will demonstrate it to myself. So Rothera's test is basically done for ketone bodies. That you must remember. So what are ketone bodies? Can anybody tell what are ketone bodies? Ketone bodies, any idea? Just tell something. Tell something. If there is a mistake, then only learn. This is a small group discussion lecture. After metabolism of protein. Bolo, bolo. No, not protein. Actually from fat. Fatty acid oxidation. We get acetone and this ketone body from fatty acid oxidation. Okay, fat metabolism, not protein metabolism. The end product of protein metabolism is urea. End product of protein metabolism is uric acid. Okay. So fatty acid oxidation end product will be basically acetyl CoA. So this Rothera test is a very important test. I mean, every test is important, every organ is important. We say that this organ might be important, brain is more important than heart, or eye is more important than ear. It is not like that. Every organ is important, every test is important. Every test has its own implication in a given situation. Somebody is required to do the ketone body test. So whatever you know, if you don't know this thing, you cannot do that. So this is done for ketone bodies in urine. What are the ketone bodies basically? These are the three ketone bodies. You see what is ketone bodies? That must be a ketone group. ইন্টারনেটটা আছে দেখো 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 হ্যাঁ তোমাদের এত দেরি কি করে আমি বুঝতে পারলাম না সম্পর্কে আপনি এই জন্য লেটেস্ট স্টার্ট করছে এনিওয়ে সো দ্যাট ইজ ketone group. So ideally acetone and acetoacetic acid and beta are actual having ketone group. But beta hydroxybutyric acid in true sense doesn't have that ketone. So it is not actually ketone body, but it's misnomer, but it is considered ketone body. So this part you must remember that there are three things. One is acetone and acetoacetic acid and beta hydroxybutyric acid. In true sense, beta hydroxybutyric acid doesn't have any ketone group. So therefore, it is not a ketone body. But by convention it has been included. So this test procedure you try to understand. So you have done the urine test for any abnormal constituent. Which constituent? Protein you have done. How much urine you have taken? How much urine you have taken? 5 ml. 5 ml, more than 5 ml, because otherwise see top more than 3 ml. Huh?
For the Keller test we took 3 ml.
Keller test.
Keller test. Of the nitric acid of the protein.
Nitric acid test.
Sulfosalicylic
acid.
No, so there is another that is written, the nitric acid test. With that nitric acid, the ring will form at the junction of the two liquids.
Have you done it?
No, sir, we just
No, I am asking you practical things. Now there is no theoretical discussion will be there. Okay. Only interpretation part will be there. In theoretical class, theoretical issues will be definitely discussed. Here it is absolutely practical. And practical related questions. Okay. So how much you have taken during urine heat test?
Heat and acetic acid, we have to take.
How much urine? 2/3. because upper part you have heated. Here you just take a measured volume. There is 5 ml. You just suck it by pipette as you have done it earlier, as I have demonstrated. So be careful again not to include any bubble. So saturate with solid ammonium sulfate. Ammonium sulfate will be given to you. Ammonium sulfate is very much soluble in water. So how will you saturate? Any idea? Can anybody tell? How a solution you will understand that a solution is saturated.
So then no more solute can be added to the solvent.
Solute?
Then no more solute can be added to the solvent, then we call it saturation.
No. Can anybody volunteer? See, if you add solute to a solution, it will go into the solution so long the solvent will be able to dissolve it. When the solvent will not be dissolved, it will not be able to dissolve it at all. Then it will be saturated. How do you understand? Suppose you have taken a 5 ml of water and then you have started adding sodium chloride or normal sugar. You have started mixing. So 1 gram you have added, it will get mixed. 2 gram, 3 gram, 4 gram, 5 gram. After 5 grams, it will be difficult to mix. And the excess amount of solute which will not be soluble will be precipitated. So when the solution, that solute cannot be mixed into the solution, or when that solute will not go into the solution, so then it is called a saturated solution. So some solute must be present as a sediment at the bottom. So after taking 5 ml, you just go on adding sodium, this ammonium sulfate, and go on shaking vigorously. Vigorously. Why I am telling you? Otherwise, you will not know that whether it is saturated or not. So at the end, you will see a precipitate. Once you see the precipitate, try to again shake it. If you do not get it, add a little bit more to be on the safer side. Again shake it. Allow it to stand. So that undissolved solute will get settled at the bottom. Then you add the freshly sodium nitroprusside solution will be provided to you. You add 0.5 ml of sodium freshly prepared, or you just give 2 drops using a dropper, and then you mix it. Mix the solution like this. So here you will take a 5 ml of solution, 2 drops or 0.5 ml of sodium nitroprusside solution, and shake it properly so that here it will have a color. So you will see the color. So whether it is mixed properly or not. As on that day, last day you have seen the solution, the sucrose solution was not getting, or the solution which you have prepared in the benedict solution, it was not getting. Even in the vitamin C, it is remaining on the top. So then it was gradually, the solution will not be, because that was having a dense solution. So here you add freshly prepared sodium nitroprusside solution, then you mix well to get that color. And this is a tricky thing. This you add, now gradually you have to add 1 to 2 ml of ammonium, liquor ammonia. Liquor ammonia will be provided to you. That you must be able to, along the side very carefully, like this. Can you see it? Very gradually, or you can use a pipette also, but process must be very gradual so that the solution is there at the bottom, on top of which you are adding another solution. So at the end you will see a junction. At the junction between the two solutions, you will see a purple color ring. Let's see the video if it is possible, and it will be clear. Just observe. Here 3 ml it is, we have taken 5 ml. Okay. Now this is ammonium sulfate. Now add ammonium sulfate. Just go and sit down somewhere at the corner. Do not disturb them. Can you see how they are observing? You do not use gloves here because this is perhaps from foreign country, so they are very much particular. Now can you see this thing? Precipitate has formed, white precipitate. That is saturation. So that yellow color was basically urine, it was saturated. Now he is adding 2 drops of sodium nitroprusside solution. You can use it with a dropper also or 0.5 ml. Now you see the color, how you mix it. You need not require a test tube because this is a synthetic urine. It is not actual urine, so you need not use glove. So you will get the way the sodium nitroprusside solution, the liquor ammonia is delivered onto the top of the solution. So gradually he is doing. Can you see that this ring has to be shown to the examiner? So you just have. See, do not allow it to see the moment it is formed. If the examiner is around, just show the ring, and do not say the trick is here. If you shake a little bit, that ring will get disturbed. So it will not be that thick as well. I am telling you. You will get a very sharp margin. It will not be this much thick. In course of time, it will get thick. It will be widened. The more time you allow, it will get widened. Okay. So at the time of formation, it will make a sharp ring just like this one. At that time, do not shake the test tube. Shaking will alter that thing. That you must be very much careful. Okay. So just what I have said, you just see that if this is present, that means ketone body is present. Just read what has been written here. Ketone body is acetone, acetic, this is read by Rotheras test. Okay? So what is that purple color ring? What is the principle of this test? You have done the test itself. So that means basically the ketone body has reacted with that reagent, and then you have got the purple color ring. So sodium nitroprusside reacts with the ketone, forming a purple color compound in presence of ammonia. This is the actual reason for formation of that purple color. So this is the principle. You got it? আর একবার দেখে নাও ভালো করে, এই মিক্সিং করা খুব সোজা। দিস প্রসিডিউর ইজ ভেরি সিম্পল। দুটো স্টেপ আছে অনলি। স্যাচুরেশন, তিনটে স্টেপ আছে। দেয়ার ইজ স্যাচুরেশন অ্যান্ড দেন অ্যাডিশন অফ সোডিয়াম নাইট্রোক্সাইড অ্যান্ড গ্র্যাজুয়ালি দিস পার্ট ইজ ভেরি, you must be very much careful. So this I have written. So purple ring at the junction between the above two liquids, and the color will develop maximum in 15 minutes time, but you will see the color immediately. Because why 15 minutes time maximum color? Because it will get the reaction time also to be completed. দেখে নাও, মুখস্থ করো না, just try to remember right now so that you don't require to read it once before examination. In this class I am going a little bit slow so that you understand and you remember. That's it. Nothing will be asked more than this, what I will discuss in the class. In all my classes you try to remember as much as you can. Okay. So, what is the source of ketone body? As I asked in the very beginning, and she attempted to answer. So, try to attempt. Otherwise, you will not learn. She committed a mistake, so now she will not do the same mistake before the examiner. So, fatty acid breakdown. This will be discussed in detail during your metabolism class of the fatty body. You will understand how it is formed. I will briefly tell how it is formed, and one chart I will give that you must remember for examination purpose also. So, normal production, adult production is 1 milligram per deciliter, and that normal production is completely, these ketone bodies are completely oxidized by the liver. That's why there is hardly any amount, and this 1 milligram per deciliter, although it is present, it is not detectable in the urine because it doesn't appear. Just like glucose, there is a threshold for everything. Threshold for everything. After, if it reaches more than 3 milligram, then it usually appears. But there is a wide variation of renal threshold among individuals. So there is a common. It is usually said that it is more than 3 milligrams, then it will appear. But in some cases it might be higher. Some cases it might be lower also. So when it will appear, so when the liver's capacity, that ketone body formation is exceeded, liver will no longer be able to oxidize it completely. Then that will accumulate in the blood, and when that amount will increase, that amount will get filtered in the globulars as glomerular filtrate. Do you get my point? Normal production, but when the production is beyond the capacity, liver's capacity to oxidize it, then only it will accumulate in the blood, and that high amount of acid, this ketone body, will then be filtered also in the glomerular, and in the renal tubule, it will be excreted from the glomerular to renal tubule, ureter, then to urine. So it is positive in two conditions. Remember, one is diabetes mellitus, one is starvation. Normal diabetes mellitus, no. Uncontrolled severe. Remember this thing. So uncontrolled means this diabetes blood sugar could not be controlled in a patient. The blood sugar level is very high despite aggressive treatment on all types of treatment, or the patient is ignorant. Patient did not comply to the treatment. You have advised that you take insulin, you take medication, the patient has not taken. He has recourse to some other form of therapy, or the insulin perhaps has been destroyed in the process of storage. That is a common problem also. I am telling you, most of the patient will take, and this has happened in my case also, that I found very high blood glucose level in one patient and casually asked, how do you store insulin? Insulin is to be stored in the refrigerator, and nobody told him. And he used to keep the insulin on his book pocket in the start and open. He used to go to the factory. So that insulin was destroyed. So he was taking insulin, but insulin is totally useless. So that is again will cause, although he is taking the drugs, similarly drugs storage are very important. Properly you have to instruct. The medicine has to be kept at a particular storage temperature which is indicated. Otherwise it will be destroyed. The same thing happened. So uncontrolled severe diabetes mellitus due to any cause. Either the patient is presenting for the first time, patient did not know at all that I had a diabetes. There is practically no symptom, or the symptom was that he ignored, or there is somebody who could not diagnose it. So patient is presenting directly with ketone body formation in an advanced stage. That is possible. Second possibility is the patient is not compliant to the medication. Patient is not taking medicine. It is normally seen in type 1. And there are two types of diabetes mainly. One is type 1 and type 2. Type 1 is insulin dependent. Means they require insulin from the very beginning. And the type 2 patients are basically the patients who take medicines, who are controlled on medicines, they belong to type 2. But at one point of time, these type 2 patients, because of the destruction of the beta cells, progressive destruction of the beta cells, over a period of time, maybe 5 years, 6 years, 10 years, 15 years, 20 years, all the beta cells will be destroyed by the disease process. So they will not be able to produce insulin anymore. So they will also require insulin. So that is a primary OHA failure, primary oral hypoglycemic agent failure. তখনও insulin দেওয়া হয় at that point of time. So you just remember this uncontrolled severe diabetes usually occurs in type 1 diabetes mellitus and prolonged starvation, just like this recent Andivar case. Somebody is fasting prolonged and doctors are monitoring blood glucose level and ketone body basically. So prolonged starvation, normally 1 or 2 days starvation, it will not occur. Why? Because if you do not take any food, liver is having adequate amount of glycogen. That glycogen will be broken down. And that will last for 12 to 24 hours. So even if you remain without food for 12 hours, you will not have that ketosis. Now, when that glycogen storage will be exhausted, then some energy has to be obtained from somewhere else. So usually fat is broken down into fatty acids, from where the acetyl-CoA is formed and it is channelized into the TCA cycle to get energy. At one point of time, again, this acetyl-CoA, this TCA cycle system will be saturated. So then, at that only acetyl-CoA will be produced in excess amount, and that cannot be metabolized, and then the ketone body formation. So prolonged starvation, not 1 or 2 days. And it depends on the reserve capacity of the patient also, or the individual. Everybody doesn't have the equal capacity. So somebody can tolerate for say 2 to 3 days, somebody might be having ketosis after 5 days, 7 days. In true sense, if he stops completely, but if he takes some food, then this is a clear example whether he is really on starvation or not. Faking starvation and demonstrating in front of public is very easy. Now, it is you have to identify whether he is faking or she is faking or not. So that is the point here. How will you check it? So it is basically producing acid. So that's why it is called metabolic acidosis. Both conditions are called metabolic acidosis. When that is acidosis in the body tries to compensate it to make the pH close to body's normal blood pH, that is 7.4. So what it happens, there is a compensatory mechanism. Now, you know urine is normally acidic, slightly acidic, but the more the acidosis, urine pH will be severely, and it will go down to 4.6 in severe cases. So kidney will also try to excrete that extra amount of acid, but at point of time it will again fail. And blood pH normally, which is maintained at about 7.35 to 7.45 at maximum, lower limit or upper limit. So that will again drop here. So whether somebody is faking or not, you are having a biochemical parameter, and here you will be asked to temper the report. After this thing, there are two conditions I told you. One is starvation, one is diabetes. So diabetic, when ketosis is there, it is called diabetic ketoacidosis, DKA, or diabetes ketosis. Similarly, starvation ketoacidosis or simply starvation ketosis. So how will you differentiate between the two? Ketone body is present, whether it is starvation. Starvation, you will get a history. There is a clear-cut history of starvation. So another good point is blood sugar. Take a blood sample. If the blood glucose is very high or plasma glucose is very high, then it is diabetic ketoacidosis. So when ketone body is present in any sample, if you are given a question, ketone body is present in the urine, but blood glucose level is normal or slightly lower, then that is not actually diabetic ketoacidosis. Okay. So here it will be very low plasma glucose, otherwise it will not happen. So basic differentiation is by doing the blood glucose test. Glycosuria, that I'll tell in glycosuria class, there is a wide variation from individual to individual. Of course, during that period of time, you will get urine sugar also positive. Urine glucose will be positive also. Yes, you will get it. When diabetic ketoacidosis will be there, urine sugar, urine glucose will also be present. Yes, you can do it. Given a good suggestion also. For urine, you can also do that. Same urine. Yes. But only thing is that urine you will not get here. It will be negative again. If you do a urine glucose test, it will be negative because there will be low plasma glucose. Urine you can do it. Add urine with it. Plasma glucose, oblique urine glucose. Good point I forgot basically to mention. দেখতে পাচ্ছ? Somebody is thinking and giving a suggestion. That is what is desired. And at some points of time I will tell wrong things deliberately, just to take your attention whether you are listening or not. And that my school teacher used to do that thing. And every time I used to get scolded that you are not listening properly. So he used to throw the chalk on the ceiling and he used to scold me like that. Why you are not listening? So this I will do also. So this pathway, it will come as examiner. This will be asked that you must tell. I mean non-stop. This is available in the book. You can just now and for understanding sake and remembering sake, you will say, see the acetyl-CoA I told you will be formed at the end of beta oxidation. So 2 molecules of acetyl-CoA will be again, that will be in excess amount. This cannot be metabolized. So these will form finally acetoacetate. So beta from 2 molecules of acetyl-CoA, then beta hydroxy ethyl butyl CoA, HMG-CoA, from there to acetoacetate. And acetoacetate, there will be dehydrogenation, that is oxidation, and it will form beta hydroxy butyrate, and these will be spontaneously decarboxylated to form acetone. So these enzymes and this pathway you have to remember so long you remain in the medical practice. Because even if you do not do biochemistry, for clinical purposes you will be required to know this thing, where from it has come. Okay. So this part I will tell you. See, during diabetes ketoacidosis, once the metabolic of carbohydrates is told to you, you will know about different enzymes. Then you will know actually how diabetes ketoacidosis occurs. What happens basically I am telling you in diabetes and starvation. In diabetes this is a problem of abundance. There is glucose in abundance around the cell, but cells are not able to take up the glucose because insulin is deficient. So despite having glucose, cells are unable to utilize glucose. And starvation, it's a problem of paucity. When there is really absence of glucose, not an adequate amount of glucose. So cells are not able to utilize the glucose. Where there is, despite having adequate amount of glucose, cells are not capable because of the insulin deficiency. Here there is no insulin deficiency. So because there is a real deficiency of glucose in the blood, that's why this breakdown of fat occurs. So this pathway I will tell you. In diabetes actually two types of coma occurs. One is diabetic ketoacidosis, one is hyperosmotic coma. That I will tell in diabetes class if I take the diabetes class. This chart, how this actually it forms, you can see the absolute insulin deficiency relative with this you will not understand at this stage. So there is one more test that is called Garhard test, which you will not do it. I am telling you for theoretical knowledge. So again, this it is called ferric chloride test. 5 ml of urine, ferric chloride add drop by drop, then you will get a purplish color. It will indicate acidosis. Sometimes it lasts like false positive, as in glucose. With salicylates, phenol, antipyrine, these are the drugs. If somebody takes it, then it can give also positive result. Now, how to rule it out? Heat the urine and test the test tube. No color indicates that the original color is due to ketone body. So this is Goddard test. So this is formal end of this actual class. Now I am telling you, it is commonly said when the blood glucose level, at what blood glucose level ketoacidosis occurs. There is one big question. So it varies. It varies from person to person. Like somebody can have a coma, this ketoacidosis at 500 milligram blood glucose level, somebody can have 1000, somebody having 1500, somebody 2000, we don't know. We have a nurse in our hospital who used to maintain a blood glucose level of 800 milligram and without that level he could not work, she could not work. And when our blood sugar glucose level used to be below 400, which is quite high when ketoacidosis occurred, she used to suffer from hypoglycemia. So her body was set at some higher point of time. So I have seen, this is from my own actual study. This is the end of this class. I am telling you, see, even in the OPD I am telling you, you will get this type of figures. These are abnormally high figures. You see 874. And this person is a chemistry teacher known to me. He came by motorcycle driving to the hospital and gave the blood. And I told him, I will not allow you to drive, I will drop you with my car. Then what happened? I will go out to have a cup of tea with you at your house during my working hours. But I didn't know whether he will sustain an accident or not. What happened? The insulin নিয়েছিলাম, insulin নিয়ে তো আমরা নিয়েছেন, ঠিকঠাক করে নিয়েছেন না, দুদিন একটু গড়বড় করেছি, ভর্তি আইসিইউতে নিয়ে গিয়ে ট্রেনে ভর্তি করেছি, ঘর থেকে তুলে নিয়ে ওনার মিসেসকে তুললাম, চলুন গাড়িতে, এদিক ওদিক কিছু করা যাবে না। Similarly, all this type of, when they 640, can you imagine? He came for the first time and left the hospital. He did not have any symptom. And the highest level of PP blood glucose I have seen, it is 1980, and this is a housewife, and she left also. I contacted her husband through intercom mobile. He was working in the factory. He is not aware of that his wife is having at all any disease or any symptom. So again I gave the report to the emergency ward, told everything to detail, and informed to the person that I have given the report of the emergency. I told the doctor to get your wife admitted. So when you think something abnormal, what I used to practice, you have to try to contact the best way you can do it. Otherwise, how people will know you? That's why this type of, and you do not see. I could have manipulated here. I don't manipulate any result. So this is asymptomatic, very severe hyperglycemia. People, many doctor might comment, this is a wrong report, you get it done from some other laboratory. Don't think that same point, on the next day you will get the same report. That may be lower, that may be higher. Do not accept that thing. The laboratory, when reporting something so high, they are also conscious. Suppose you are recording somebody's blood pressure very high or somebody's blood sugar pressure very low, you will check 2 to 3 times. Pulse very low, very high, you will check 2 to 3 times. Same thing happens in the laboratory. So laboratory giving a very abnormal report, do not blame the laboratory immediately.